All right, thank you all for rejoining. So Selena could get back in. Okay, I'm gonna go back to our PowerPoint here. Okay. Okay, so I was talking about sickle cell. Kids who have been diagnosed with sickle cell anemia, typically after they've been in a crisis situation where they've been hospitalized, especially, they will be on prophylactic antibiotics, typically in the form of penicillin, for up to 5 years potentially after that hospitalization. And the goal is just to prevent them from having more infections that could cause them to have sickle cell crisis. Okay. Monitoring a reticulocyte count is regularly done to make sure that their bone marrow is functioning as it needs to. Okay, so they'll have frequent, well, not super frequent blood draws because you don't want to pull off too much, but they'll have routine blood work done, typically every 3 to 6 months. And usually that's a reticulocyte count and a CBC. Okay. So if blood transfusions, so if a kiddo is early on in the crisis and a blood transfusion is given, then that reduces the risk of ischemia. Okay. So prognosis of sickle cell anemia, there's no cure except possibly bone marrow transplantation. So if kiddos have a bone marrow transplant, then sometimes you'll see some sickle cell anemia reversal. Oh, somebody's muted. Does somebody have a question? No? Okay. So you may see some reversal if they have a bone marrow transplant. Supportive care is preventing those sickling episodes. So these kids really, really need to stay hydrated. Okay, that's the biggest thing with sickle cell anemia to prevent those crisis situations is keeping them hydrated and keeping their oxygen at an appropriate level. Okay, because they're having they're immune compromised because of the number of bacterial infections that they have. Okay, that goes along with the sickle cell anemia. They're more at risk for bacterial infections. Okay, so the leading cause of death in young children with sickle cell disease is bacterial infections. So that's why they're on the prophylactic antibiotics. Okay, typically these kids live until they're in their 50s usually. After their 50s, not everybody is continuing to be able to maintain the adequate hydration and oxygenation. Okay. So in educating the child and the family about sickle cell disease, like I said, going earlier intervention, the better for those kids when they're having sickle cell crisis, giving them their preventative prophylactic antibiotics of penicillin, and explaining the importance of that, because if they're not taking that appropriately, then they're more risk for infection, which then leads to them having more potential for crisis. Okay. Recognizing the signs of strokes and respiratory distress because of that sickling episode. Okay. So these kids are at risk for strokes. Okay. You want the child to participate in sports and all of that as much as possible, but you have to educate the parents that these kids will need to have a lot more hydration to be able for them to maintain those activities compared to another kiddo that does not have sickle cell disease. Okay. All right. Any questions on sickle cell before we move to thalassemias? No? Okay. Thalassemia, this is another hemoglobinopathy. So this is a genetic disorder. Okay. So what happens is, you can see here, instead of having good circular red blood cells, we're kind of like a square shape almost of the red blood cell. Okay. So this leads to the hemoglobin and the red blood cell having more destruction. Okay. And so their life, the red blood cell's life specifically when they have thalassemia, is a shortened length. Okay. So there's just a lot of destruction. They're still creating the same amount of red blood cells. You see this commonly in people who came from descendants of those in the Mediterranean. Okay, it's more common in Mediterranean population. Okay, so there's 4 types of thalassemia. Thalassemia minor, which is an asymptomatic silent carrier. Okay, so they're not going to have any symptoms, any anemia. They just have thalassemia. Okay. Thalassemia trait, you're going to see a mild microcytic anemia. Okay, so the shape is going to be affected. Okay. Thalassemia intermittent, you're going to see moderate to severe anemia plus enlarged spleen or splenomegaly. Okay. Thalassemia major, this is Cooley's anemia. This is probably the most common thalassemia most people think about. This causes severe anemia and they need transfusions to be able to survive. Okay. Thalassemia is diagnosed. Of course, they're going to have low hematocrit and low hemoglobin levels. You'll see red blood cell changes in the shape of the red blood cells. Okay, and the destruction. Okay. Usually, thalassemia may not be found out right away in early infancy. It may come about towards 6 months of age when they have progressive, very low hemoglobins and they're not growing well. Okay. Blood transfusions are needed to maintain normal hemoglobin levels on these kids with Cooley's anemia specifically. Okay. So you will have to treat these kids with iron chelating drugs. Okay. This binds the excess iron because you're giving them infusions so often. Okay. This binds that excess iron that the body doesn't need and then causes it to be excreted by the kidneys. If they're not giving this iron chelating drugs, then they have too much iron accumulating and they can have complications from elevated iron. Okay. Managing thalassemia, of course, promoting compliance with their transfusions and then that chelation therapy that happens during the transfusion. Okay, which is what we just talked about, the iron binding medications. Okay. Of course, having to have routine chelation therapy and also transfusions is very stressful for children. So trying to work on some coping mechanisms to treat that anxiety about having to have these infusions. Encouraging and helping these children and the families adjust to their chronic illness. This is a chronic thing, something that kids will have to deal with throughout their whole life, okay, with thalassemia. Okay. And then obviously observing for complications with having blood transfusions routinely. So thalassemia, these kids live into adulthood, typically pretty normal lives, other than having to have routine transfusions. Okay. As long as they're doing their routine transfusions, they usually have a pretty typical life. Most common causes of death are heart disease. After having their spleen removed, they get sepsis or multi-organ failure. And that usually happens, like I said, if they're not doing their chelation along with their transfusions. Bone marrow transplant is a potential cure for thalassemia. Okay. Okay. and looking at aplastic anemia. So pancytopenia means depression of all formed elements of the blood. So that's going to be low red blood cell count, which is anemia, low white blood cell count, okay, which is leukopenia, and low thrombocytopenia, which is low platelets. Okay, so aplastic anemia means all of these things are suppressed. Okay, this causes hypoplastic anemia, which, like I said, you can also see hypoplastic anemia, which is depression of the red blood cells, but that the white cells and the platelets are normal. So that's kind of a subtype of aplastic anemia. But typically, when you're thinking of aplastic anemia, you see kids have depression in all red blood cells, white blood cells, and your platelets. Okay. This can happen from something like an immune therapy or like chemotherapy can cause aplastic anemia because it's killing off the cancer cells, but also your bone marrow stimulation is decreased. Okay, so your red blood cells, your white blood cells, your platelets are all attacked by chemotherapy. Okay, so that would be like a secondary cause of aplastic anemia. Some kids are born, so they have congenital primary aplastic anemia. Okay, and that's an inherited thing. Diagnosis, obviously, that goes along with the CBC. That's all going to be suppressed, or a portion of it will be suppressed. And then management is immunosuppression and ultimately bone marrow transplant is what these kiddos are going to need. So you're going to manage them similar to how you would manage an immunosuppressed kiddo who's at risk for infection, like a cancer kiddo who's getting chemotherapy. So if they have a fever, it's an emergency, okay, because they have nothing to fight that infection off. Okay, so these kids are probably going to need very close monitoring in a hospital setting until they have their bone marrow transplant. Okay. Defects in hemostasis. Okay, so this is looking at hemophilia. Okay, so vascular influence. So if kids don't have really great vasculature, then that's going to be a part of hemostasis. Okay, that's going to increase their risk for clots. Okay, platelets play into that as well. So if they have low platelets, or high platelets, then they're going to be more at risk for clots. Okay, looking at hemophilia. So this is hereditary. Okay, this is a bleeding disorder that then affects specific clotting factors based on whichever they are deficient in. Okay, 80% of cases are X-linked recessive. So that means boys will be more affected. Okay. So identifying the specific factor deficiency, and then that allows for the specific treatment. So going into some types of hemophilia. So hemophilia A, this is your classic type of hemophilia most people think of. This is factor VIII deficiency. Okay. So they're not creating factor VIII. That leads to the prolonged bleeding. Okay. Hemophilia B, also known as Christmas disease, is a deficiency in factor IX. Okay. Von Willebrand also falls under hemophilia. This is a deficiency in both von Willebrand factor and factor 13. Okay. So based on the type of hemophilia depends on what sort of intervention or management you're going to do. So diagnosing hemophilia, these kids will have prolonged bleeding episodes. Okay, they might have some ecchymosis, so really profound bruising that they can't explain. And then hemoarthritis, there might even be some blood within the joints that accumulates. Okay, So they'll have some swelling and kind of some bruising looking within their joints. Okay. It's X-linked inherited. So like I said, boys are going to be more likely to be affected because they only have one of those X chromosomes. Okay. Looking at labs, you'll have to look at the specific clotting factors. And then depending on whichever of those factors is deficient, that's how you get your diagnosis, whether it's hemophilia A or B or von Willebrand's. Okay. Also, these kids will have prolonged partial thromboplastin time, so prolonged PTT on their blood work. Usually they have a normal platelet count and a normal parathyroid or hormone level and a normal fibrinogen. Okay. So managing their hemophilia depends on their missing clotting factor. So if they're missing factor 8, which was hemophilia A, replacing that will allow them to live pretty normal lives. Okay. So DDAVP or desmopressin, this can be given IV or nasally. Okay. This is given 2 to 4 times a day. It increases factor 8. So this is used for hemophilia A because it's affecting factor 8. It will not help if they have Christmas disease or hemophilia B or von Willebrand's. Okay. Aminocoporic acid, you'll see that. This prevents the clots destruction. Okay. So it helps them be able to clot easier. Usually they can do this at home. Do you have a question, Samantha?
I don't, I'm sorry.
Okay, no, you're fine. You just came unmuted. Okay. So your goal with hemophilia is obviously to prevent bleeding. Okay. So trying to keep them in an environment where they're not at increased risk for bleeding. So safe environmental kind of thing, dental hygiene, having dental care is really important. You know, if they're not brushing their teeth really routinely, then they're going to be more at risk for bleeding. So talking with them about that, pushing rest, okay, doing ice to the joints that may be affected, compression to those joints and elevating, just like if you had a, you know, orthopedic kind of injury. Okay. The bleeding, if these kids are really restricted in their activity, that can increase their risk for bleeding. Okay. So they won't be in, you know, high contact sports, most likely, typically, is not encouraged, but you want them to be active in some way. Okay. Since it's genetic counseling a lot of times is utilized with these kids. Prognosis of hemophilia, typically if it's mild to moderate, which is usually hemophilia A, they live pretty typical lives. Okay. They just have to kind of keep an eye on their bleeding time and their factors, clotting factors. Okay. Gene therapy is something that they're looking into for hemophilia. And then working on copying factor 8 into a gene and then introducing that to the kiddos. So that way it kind of reverses their hemophilia A. Okay, so that's something that's kind of in the works. If they have pretty severe hemophilia, then they typically, you know, have to be hospitalized and monitored more closely because of their risk of bleeding. Okay, immune thrombocytopenia. This is also known as idiopathic thrombocytopenic purpura, ITP. You'll see that. It is an acquired hemorrhagic disorder that has thrombocytopenia, so excessive destruction of platelets. So they're making normal platelets, but there's a lot of destruction. Okay. And then it causes purpura, which are discolor petechiae that are under the skin. So little tiny pinpoint bruising. Okay. Like I said, they're making normal blood cells and all of that. They have normal bone marrow function. Okay. But because of the destructions of the platelets, their bone marrow starts cranking out more immature platelets and eosinophils to try and make up for the destruction of the platelets that's going on. Okay. This is an acute self-limiting illness, so it usually follows a upper respiratory illness or like mono. I've seen it after mono. Usually lasts, a few weeks potentially, and then resolves. Okay. There is a chronic form that means that it lasts for those kids longer than 12 months. Okay. Interesting fact, I actually had ITP as a 3-year-old when it was very first kind of being identified. And at that time, the treatment was giving you platelet transfusions, which actually they've come to find out that worsens the effects on the body. So now treatment is IVIG. So IV immune globulin, we talked about that last week with Kawasaki's. Okay, so we give them IVIG. We support them, like their bone pain. We support them with their anti-D antibodies as well. Okay. Sometimes kids will get steroids. Okay. It's a self-limiting, typically without major complications. This picture is showing you kind of what the petechiae can look like. Okay. Managing wise, you're going to want to try to avoid poking these kids because they're not going to be able to clot because of their decreased platelets. Okay, so you're going to monitor them for bleeding. They're going to have routine blood counts completed. And like I said, sometimes these kids are given corticosteroids as well to help with their immune function. Okay, epistaxis, nosebleed. Okay, isolated or transient epistaxis is very common in childhood. A lot of times it can be driven by like allergy flare-ups, or if kids are picking their nose, they can cause bloody noses. But also prolonged recurrent nosebleeds are kind of indicative of vascular abnormalities, low platelet count, so thrombocytopenia, troubles with clotting factor deficiencies, so von Willebrand's, which we just talked about as a form of hemophilia and hemophilia. Also, you can see prolonged, frequent, recurrent epistaxis in kids who have leukemia. Okay, and that comes about typically from the chemotherapy. So if a kiddo is having a bloody nose, you want to remain calm, keep the kiddo calm so they're not ingesting all of that blood. Lean them forward, okay, and then apply pressure at Castlebeck's triangle. So that is right below, like if you feel on your nose, right below the bridge of your nose. You can pinch right there, and you can still breathe through your nose, but that's going to stop the bleeding. Continuous pressure for 10 minutes. Now, trying to do that with a kiddo is difficult, but to say that you applied adequate pressure, that's applying it for 10 minutes. If it's not stopping within 10 minutes, they need to go to the ER. Okay. Like I said, having them sit up and lean forward. You'll see a lot of people with bloody noses, they'll want to lean back. You don't want to encourage that because then they're just inhaling the blood. Okay. Like I said, if it doesn't stop within 10 minutes, they need to be evaluated. right away. Okay, looking at HIV and AIDS. So this is typically in the pediatric population. This is happens during birth transmission, or during adolescence. Okay, when they're making risky sexual health choices. Okay, heart therapy typically is done prenatally or perinatally, excuse me, from 22 weeks on until the week after birth. So they're doing those antiretrovirals, okay, to hopefully prevent transmission to that baby. Okay. And like I said, the thought is by doing the heart treatment, that infants will not contract HIV. Heart treatment or highly active antiretroviral therapy usually is comprised of three combination antiretroviral drugs. Okay, there are a lot of other antiretrovirals in the works right now. They're looking at gene therapy, all sorts of things, but right now our best bet is doing the heart treatment. Okay, the goal is to improve the immune system of that newborn and hopefully prevent them from contracting HIV. Okay, HIV is found in blood, semen, vaginal secretions, anal secretions, and breast milk. Okay, so these babies will not be able to be breastfed. Okay. Like I said, they're coming up with a bunch of new combination medications. This has decreased the death rate. They are doing more prophylactic, like so prior to sexual activity, which, like I said, that's more towards the adolescent side. But they are coming up with a lot more prophylactic preventatives for HIV. Okay. So those are all still kind of in the works. Obviously, recognizing that the kiddo has contracted HIV earlier decreases the risk of complications. Okay. The biggest cause of death in children with HIV, especially infants, is pneumocystic coronary pneumonia. So PCP pneumonia. Okay. Frequently, you'll see PCP pneumonia happen between ages 3 to 6 months of age. It can happen later in life as well, but most frequently you see it between 3 and 6 months of age in infants that are affected. Okay. Educating parents on the management of HIV and prevention, counseling for adolescents, so safe sex practices. Okay. Pain management is going to be involved, psychosocial kind of aspects, of course, with it being kind of it used to be a controversial kind of diagnosis. Sometimes some of the psychosocial effects of that is still kind of involved. And then, of course, it's confidential, just like any other part of medical history. But speaking with parents, that is confidential as well. Okay. Okay, so we talked about a lot of different technologies for the management of hematologic and immune dysfunction. That included blood transfusions. So your blood transfusions can be either just packed red blood cells or PRBCs. So that's something you would do for, like a trauma. Okay. They would just get, or just anemia. Okay. They can also get platelets alone. Okay. You want to be monitoring them very closely for transfusion reactions. Okay. You are going to be using a pump, an IV pump, every time you're giving blood. Okay. And then a lot of places have, a blood guideline, like a policy, where there have to be 2 nurses that check it, 2 nurses that check the pump, routine vital signs obtained while being while receiving the blood. Okay. Apheresis. So this is, you can see that that's what's happening here. So they're pulling the blood out, separating the components, and then reinfusing a portion of the blood. So this is used to save platelets in healthy donors. This is how they do platelet infusions. Okay, or get the platelets for infusions, excuse me. Okay, so this is how they pull platelets out from your blood to separate it and then give those donors back their blood components. Bone marrow aspiration, so that's going to be pulling out some of those cells to see how the bone marrow is working. Okay. Bone marrow aspiration is not a comfortable procedure. Okay, so you want to be upfront with these kids. It's they're gonna try, we're gonna try and make it as comfortable as possible, but it's painful. Okay, so you might need to be pre-medicating them with some IV pain meds prior to bone marrow aspiration. Okay. Okay, so when parents have sickle cell trait, what is the chance that their children will have sickle cell anemia?
25%.
Exactly. Good. All right. We're going to go to chapter 44, talking about cancer. Okay. Pediatric cancers. Okay. So neoplastic disorders. This is the leading cause of death after infancy is cancer in children. Okay. Almost half of all childhood cancers involve the blood or blood forming organs. So that means like your leukemia and your lymphomas. Okay. That's most common diagnoses in pediatrics for cancer. So when talking about leukemia first, this is a broad group of cancers that affect the bone marrow and the lymphatic system. Okay. Depends on the severity with how complex it is. So there's a lot of different factors that go into leukemia. They classify it based on how complex the heterogeneity is. Okay. This is the most common form of childhood cancer is leukemia. Okay. Even between leukemia and lymphoma, leukemia is number one. Typically about 3 or 4 cases per 100,000 Caucasian children, less than 15. Okay. So something that's more prominent in Caucasian children. More frequent in boys if they're over a year of age. Kids with Down syndrome are at higher risk for leukemia. Okay. So if kids have Down syndrome, they're at higher risk for septal defects. They're at higher risk for leukemia. They're at higher risk for hypothyroidism. Okay. Usually leukemia is, the peak onset is between 2 years and 5 years of age. About a 95% survivability rate at this point. Okay. Pathophysiology of leukemia. So what happens in leukemia? It's an unrestricted proliferation of of immature white blood cells in the blood forming tissues of the body. So in the bone marrow. Okay, there's just massive destruction of the white blood cells specifically. Liver and spleen are most severely affected organs because of all that destruction, having to manage the breakdown of those cells. Leukemia will look like how solid tumors look, like based on their labs and all of that. Okay. So in diagnosing, obviously history and physical manifestations. So kids will be, having some pain, they'll be fatigued, they'll have intermittent fevers without, an illness. They'll have, like I said, a lot of fatigue, bruising. They may be more pale appearing. Okay, getting a lot of infections. Okay. And in diagnosing, initially you'll get a CBC and then they'll do a blood smear on that. And on the blood smear, you will see immature leukocytes, so immature white blood cells. Okay. And overall, usually you see low blood cell counts across the board. So they'll have really immature white blood cells, so monocytes, leukocytes, neutrophils. So those will all be immature. And then also you won't have as many red blood cells and as many platelets as well. Lumbar puncture is done to rule in or rule out any central nervous system involvement. And then it's confirmed by doing bone marrow aspiration. So you're going to aspirate, pull some of that fluid out of the bone marrow, and then also then biopsy that. Okay. Like we talked about, being honest that a bone marrow aspiration and biopsy and lumbar punctures are not overly comfortable, but trying to keep these kids as comfortable as possible through these harmful procedures. Okay. Therapeutic management of leukemia. So there's 4 phases of therapy. So once a kiddo is diagnosed, they're going to have the induction therapy, which is for a 4 to 6 weeks period of time with very aggressive chemotherapy, a lot of times corticosteroids. So prednisone is a part of that plan. With leukemia specifically, they don't typically do radiation because it's of the blood. But if they have a solid tumor, then radiation is also in the induction phase. The goal of induction is getting that kiddo to remission. So no cancer. Okay, that's the goal in the first 4 to 6 weeks. Then they progress into if they have central nervous system involvement or not, then a lot of times intrathecal chemotherapy is done, which that means we're giving chemotherapy within the intrathecal space. So within that spinal components, continents area. Okay. Intensification or consolidation therapy then comes after induction. Okay. And then that's the goal of that portion of the therapy is to eradicate any other potential leukemic cells that are left. Okay. And then on to maintenance. In maintenance therapy, the goal is to continue to not have any signs of cancer. And maintenance therapies look different for different cancer diagnoses. Okay. So the length of time of maintenance for leukemia versus neuroblastoma is going to be a different length of time. Okay. Hematopoietic stem cell transplantation for leukemia HSCT. So there's 2 different types of stem cell transplants that can occur. So if parents, so you guys have probably heard of, or if you've been pregnant or expecting a baby, they talk about, obtaining stem cells. Okay. So like saving that placenta or saving the stem cells. So if you guys wind up saving stem cells and putting them in a bank somewhere to hold them, later in life, if kids have leukemia, or if you have leukemia, then say your parents saved your stem cells, then you can actually have an autologous stem cell transplantation. So your stem cells that were saved from when you were an infant, right after delivery, can actually be given to you to hopefully correct the cancer, the leukemia. Okay. That is an autologous stem cell transplant. So you are giving your own stem cells. Okay. Allogenic stem cell transplant is you're getting stem cells from a donor. Okay. Any questions on that? Autologous versus allogenic. They have to be matched. Okay, so you have to have your antigens match, but they don't always, the donors are not always someone who's a relative of yours. A lot of people will match and they don't, share genetics. Okay. Sometimes peripheral stem cells are used. Like I said, the umbilical cord blood have a lot of stem cells. Of course, if you're getting an allogenic stem cell transplant, you have to worry about rejection. So graft versus host disease. And then from graft versus host disease, severe organ damage. If you're getting an autologous stem cell transplant because they're your own, you don't see rejection occur. Okay. All right, care management of leukemia. So preparing, you as a nurse are going to be preparing this child and the family for procedures. Okay. Using chemotherapy precautions. Okay, so protecting yourself from the chemotherapy infusions. This is, you're double gloving, you're wearing, face shields, you're wearing like contact precautions. Okay, double gloving with emptying their urine, all of that. Okay, because chemotherapy is excreted in urine. Okay, managing their pain. Okay, the other complication is because they're getting chemotherapy, which kills good cells as well as the cancer cells, is they're going to be very high risk for anemia, for bleeding, and for infection. Okay. Because of that myelosuppression that's happening because of the chemotherapy. So preventing those three things are going to be a huge part of managing a kiddo with cancer. Kids within the first few days after chemotherapy are most at risk for infections. So if they have a fever, they need to be hospitalized right away because of their neutropenia. Prognosis of leukemia, like I said, this is leukemia is probably the easiest, the most survivable cancer for kids these days. So talking with parents about the prognosis is pretty reassuring in the form of cancer. Okay. But what goes into that is their initial white blood cell count, their age that they're diagnosed, which cells are involved. Is it all of them or just, white blood cell counts or just thrombocytes? Okay. Their gender and then the karyotype analysis, and that's done during the biopsy portion. Okay. That's how they classify the type of leukemia. Obviously, if it's more complex leukemia, the prognosis isn't as good. Cancer treatment modalities. So it's a multimodal. Typically with chemotherapy, with leukemia, it's just chemotherapy. But with other tumors, if they have solid tumor, then you're going to typically see a combination potentially of surgery, radiation, and chemotherapy. Okay. The goal of surgery is to remove as many traces of the tumor and restore normal function. Okay. The goal with chemotherapy is, that's going to be provided through an infusion, usually through a port. Okay. They'll use a different combination of drug regimens based on their protocol for that specific cancer, excuse me. Okay. Like I said, you'll have to use your chemotherapy precautions. Radiation wise, the goal of radiation is to shrink down that tumor. Okay. Management for these kiddos, making sure that you're abiding by quality patient outcomes. Okay, you're abiding by those protocols and from the cancer societies. Okay, earlier detection, the better. Okay, the more likely that these kids will be cured. Signs and symptoms of cancer can include pain, intermittent fever, bleeding, or ecchymosis. So that bruising, prolonged bruising, or overly excessive bruising, and petechiae. Okay, a lot of times these kids will have a weight loss without trying, just overall fatigue. Okay, firm and large lymph nodes, typically in multiple areas of the body. Kids will also sometimes have vision changes, especially if their tumor is, within their brain or somewhere else in the neurological system. Managing side effects of treatment. Of course, like I said, your biggest concern is infection. So if kids have a fever and they have less than a 500 ANC, so absolute neutrophil count lower than 500, they are at extreme risk for septic shock. Okay, so you're going to be monitoring for the usual signs of infection and inflammation. Okay, so fevers, fatigue, all of that. Okay, these kids will have a very broad spectrum antibiotic therapy initiated right away. Prior to initiating that, they'll have multiple sets of blood cultures, usually one from their port site, so we can see if their port is their cause of infection, and then one from just a vein. Okay. Hemorrhage, like I said, that's also a risk of chemotherapy because of the platelets being affected and destroyed during chemotherapy. So platelet transfusions are usually utilized, okay? However, you want to be cautious with doing repeat transfusions of platelets because of the risk of antigen formation, okay? You'll want to be teaching parents to have these kids while they're on chemotherapy, avoiding contact sports or anything that may cause injury that increases their risk of hemorrhage. Anemia, so this is most common during the induction phase, which leads to intolerance of physical activity. Okay. Nausea and vomiting is really a common side effect of chemotherapy, so managing that. A lot of kids are utilizing synthetic cannabinoids to help manage their nausea and vomiting during chemotherapy treatments and improve their appetites. Okay. Antiemetics should be given at least 30 minutes before chemotherapy and then continued around the clock for at least 24 hours after chemotherapy is done. Okay. So things like Zofran, scopolamine patches. Some kids have Zofran and scopolamine patches. I mean, it just depends how much nausea and vomiting they're having with their infusions. Okay. Altered nutrition because of the nausea and vomiting can also be a risk. So these kids, you're going to be monitoring their growth, their weight, prealbumin, transferrin, and their albumin. Okay. They should be on high calorie, full fat, high protein, not doing reduced fat options in kids who are getting chemotherapy. Mucosal ulceration. So you'll see these kids, especially during their nadir period. So during that period where their neutrophils are dropping and they're most at risk for infection, they will have ulcerations throughout their GI tract. Very common that happens. That obviously worsens their anemia because of the pain. Okay. Trying to use a soft bristle toothbrush, soft, bland foods help. A lot of times, magic mouthwashes will be used. So things like Maalox or Mylanta and Benadryl are used to kind of coat the GI tract to increase their appetite. We do not do viscous lidocaine in kids because of the risk of overdose. Okay. If they have rectal lesions, doing some sitz baths are helpful. Neurological problems. So foot drop can happen because of the weakness and numbness and tingling that can happen secondary to chemotherapy. So that can cause difficulties with ambulation. Severe constipation can happen. A lot of times these kids are getting oral opiate pain medications, which increases the risk of constipation further. So monitoring that they're having regular stools and not having a lot of straining along with that. Okay. Severe jaw pain can also be seen with chemotherapy. Hemorrhagic cystitis. Okay, so this can happen because of them not being hydrated enough. So a lot of the chemotherapies, you have to make sure that their specific gravity is better than 1010. So 1.010 on their specific gravity before they start those chemo transfusions or infusions. Okay. So a lot of times they'll be given like IV fluid boluses before they're given the chemotherapy. So if parents are noticing any blood in the urine or problems, painful urination, they should have their kiddo looked at right away. Okay, alopecia, of course, losing our hair is a pretty common side effect of chemotherapy as well. Talking about, kids may want to cut their hair short or shave their head totally during this time period. Or some people will just let their hair come out in clumps. Okay. Usually regrowth once chemotherapy is done starts within 3 to 6 months. Steroids, like I said, they are commonly used in induction plans for different cancers. So managing those side effects. So that cushingoid appearance is what you're seeing here in these kids. So that moon face, the buffalo hump, all of that you can see from excessive steroid use. So making sure these kids aren't having a lot of sodium to reduce their fluid retention. Okay. Prepping them for procedures. Typically, it's going to be sedation. For older kids, you'll see that maybe they won't utilize sedation, but a lot of times it's sedated when they're having, like taps and things done. Okay. Providing them emotional support, applying topical anesthetics before accessing their ports or before doing blood draws can be really beneficial. Okay. And then they will usually do a very deep injection of lidocaine prior to the bone marrow biopsy. Pain management, like I said, a lot of times they use opiate analgesics, but also non-opiate. They'll also utilize, just different distraction techniques in these kids as well. A lot of times you pull in interdisciplinary pain management teams or palliative care kind of teams, okay, in kids with cancer diagnoses. Okay. And then your pain medication is titrated based on the side effects or the pain signals that the kiddos are having. Remember your pain management, your pain charts, your faces and the ages and FLAC. Maintaining health. Kids who have cancer still need their basic routine health care. Okay, so they still need routine dental care. They still need physicals with their providers. Okay, they still need to make sure that they're having their routine vaccines. Okay, now as far as vaccines, you cannot give them any live attenuated vaccines while they're on chemotherapy. Okay, so that would be chickenpox, MMR, measles, mumps, rubella. Okay. We cannot give them those because there's that risk of them potentially contracting those viruses. Okay. Inactivated or deadened virus vaccines can be given. So like your tetanus, all of that can still be given. Okay. You don't have to worry about family members taking live vaccines. Okay. Now, if a kiddo with cancer contracts something like chickenpox, that's very dangerous. So they will need the immune globulin for chickenpox injection. Okay. But they will not get the chickenpox vaccine in that case. Okay. Lymphomas. So there's Hodgkin's and non-Hodgkin's. Hodgkin's is more prevalent in kids 15 to 19, and non-Hodgkin's is more prevalent in kids less than 14. So Hodgkin's is a neoplastic disease that originates in your lymph nodes. Okay. It usually metastasizes to the spleen, the liver, bone marrow, lungs, and other tissues. So these you will see, the enlarged lymph nodes. Usually, oh, did someone have a question?
Is that dangerous, Mrs. Baker?
Uh,
The lymphoma?
lymphoma? Yes. Yeah, it's a cancer. Yep.
It is?
Yep.
Because I know somebody that has something like that, but he went to the doctor. They didn't say it was cancer, but it's not.
It might just be like an enlarged lymph node or something.
It's like I don't even know how to describe it. It's like there is like some air inside of it. It's not hard. If you press it, you're in.
Like an abscess or something, maybe instead of
Yeah,
a
it's
cancer.
not. It's not. It's not cancer.
Right. But
Oh,
yes, lymphoma is cancer. So
oh,
Hodgkin's and non-Hodgkin's are cancerous. So
yeah. Because he went to
painless.
the doctor. They said it's nothing.
Okay. Well, that's good.
Yeah.
Um, Usually these lymph nodes are painless, enlarged, swollen, usually on the cervical, so like the neck, and then this supraclavicular lymph nodes, so like right over the clavicle, your lymph nodes there. Um, which the neck lymph nodes, sometimes those can be enlarged with different illnesses. But typically your supraclavicular lymph nodes should not be enlarged, even with acute illnesses. So if that's something that's noticed, then a lot of times that's a lot more concerning for Hodgkin's disease. Like I said, these lymph nodes are painless. So even though it looks like it's really swollen on these two boys, um, it's painless. Okay. Cough, fever, abdominal discomfort, just kind of decreased appetite, weight loss, night sweats. Those are all signs potentially of Hodgkin's lymphoma. Diagnosed based on history and physical, you're going to get a CBC, uric acid, look at their liver function, okay, alkaphosphatase, their SED rate, their CRP, okay, a UA, and usually radiologic tests. So sometimes ultrasounds are done, CTs, things like that. A lymph node biopsy is completed of these enlarged lymph nodes. And to confirm Hodgkin's disease, there's a presence of Sternberg read cells. Therapeutic management of Hodgkin's disease typically includes both radiation and chemotherapy. Okay. Long-term survival is excellent for Hodgkin's disease, especially if it's found early on. Okay. Aggressive therapy early on reduces the chances of complications. You, as the nurse, are going to be preparing these kids and families for the diagnostic procedures. So, for the biopsies, the blood work, all of that, managing side effects of radiation and chemotherapy, and supporting these kids. There is a concern for infertility in any kiddos that are having chemotherapy. Okay, so that needs to be a conversation since these are typically older kiddos who are going through puberty. This needs to be a conversation that's had with them. Do you, as females, do they want to have their eggs, taken and stored for future prior to chemotherapy being done, or other interventions being done because of the risk of infertility after having had chemotherapy.
And how long can the egg be froze?
for however long. I mean, there was just a baby that was born from an egg that was over 30 years old.
No, like since if the child is a kid like 17, 18, something like that, and then they're gonna have a long time before they can get married or something. I would like to know like how long you can keep the eggs to be
Yeah.
full.
So the egg that just what the baby was born from was from 1992. Had
Okay.
been frozen since 1992.
Oh,
So that's over 34 years that that
34
egg was
years.
frozen and they still had a baby from that egg.
Oh, that's good. That's good.
So I don't know how long specifically. I mean, it depends on how it's maintained and everything, but for long periods of time.
Yeah, 30 years, it's long enough.
Yes. So looking at non-Hodgkin's lymphoma, this is more frequently diagnosed in children than Hodgkin's lymphoma. Okay. So usually the disease is more diffuse, so there's more lymph node involvement. Okay. Than, just one area being enlarged, like in Hodgkin's. Okay. Um, Dissemination, this occurs early on, and it's more rapid. And a lot of times there's mediastinal involvement and invasion of the meninges of the brain. So the further along staging wise they are, there's mediastinal involvement. So you can see this here. Um, and then eventually the brain is also impacted as well. So manifestations of non-Hodgkin's versus Hodgkin's, you're going to see, depending on where the metastasis is happening. So if the cancer is metastasizing to the bone marrow and the CNS, it's going to look like leukemia. Okay. So you're going to manage it like how you would leukemia. Okay. So surgical biopsy, bone marrow aspirations, CT of the lungs and the GI tract, because those are a part of the mediastinal, which is more common that you'll see the tumors in those locations. Management, you follow the uh, different protocols based on the cancer societies. These kids will have aggressive radiation and chemotherapy. Okay, they're going to go through the induction, consolidation, maintenance, and typically they also have intrathecal chemotherapy, which is where they kind of do that bath of the CNS, the spinal column in chemotherapy. Okay, typically focus on managing the effects of chemotherapy in these kids and radiation. Okay, nervous system tumors. So looking at brain tumors, this is the most common solid tumor in childhood is a brain tumor. You do have benign and malignant tumors, okay? Depending on the specific types of cell that are involved in the tumor will depend on the severity and the categorization of that tumor, okay? Signs and symptoms, like I said, depending on where that tumor is, you'll see different signs and symptoms. So you might see hydrocephalus, you might see headache, you might see vomiting, nystagmus, so that's that darting of the eyes back and forth, ataxia, so difficulty with body movements, diabetes insipidus, okay, so they're constantly drinking, and growth failure. Diagnosis of a brain tumor, typically looking at clinical signs and symptoms, an MRI is going to be done, okay. Sometimes they do biopsy of the tumor, CT scan. A lot of times they're going to be doing lumbar punctures. However, if kids have increased intracranial pressure because of the tumor, then lumbar punctures are avoided. Okay. Management for a brain tumor, typically you're going to see radiation, or excuse me, surgery happen first, then radiation, then chemotherapy. Okay. The goal, of course, is treatment can remove the entire tumor without neurological damage. Okay. So sometimes radiation will be done before surgery. Sometimes surgery is done first. It just kind of depends. Okay. Sometimes they just get chemotherapy. So managing as a nurse, what you're going to be looking for, you're going to obviously be looking for signs and symptoms of increased intracranial pressure, especially after they've had a brain surgery. Okay. Preparing the family for the diagnostic and the operative procedures. Okay, you're going to be looking for post-op complications for these kids. So your positioning, you're going to have to maintain their head of bed at least 30 degrees. Okay, looking at the intracranial pressure, routine vital signs, all of that, and managing their fluid status. Okay, trying to promote these kiddos' optimum functioning. Okay, neuroblastoma. So it says neuroblastoma, you think right brain, but actually neuroblastoma is most commonly found in the abdomen. Can also be found in the chest. Okay. Kids will have severe bone pain with neuroblastoma. And depending on where the mass starts, depends on the progression of treatment. Neuroblastoma is not as easy to cure as both lymphoma and leukemia. Okay. You'll see exophthalmos sometimes, so protrusion of the eyes, if the tumor has progressed to the brain, metastasized to the brain. If they have the lump or the tumor on their chest, then that, you're more worried about respiratory compromise. Okay. Typically, these kiddos have a tumor that's found in the abdomen. You want to make sure, you're not pushing on that too much. But a lot of times the tumor is felt in the abdomen by either a nurse or the provider, and that's how it's diagnosed. Okay. Looking in care management, it depends on the location of the tumor. This is about 6% of all malignancies. And then chemotherapy, radiation is usually included in neuroblastoma treatment. Continue working with the family on coping and support and monitoring, the effects of chemotherapy. Okay, bone tumors. Typically, you see pain at the affected site, so wherever the tumor is at. Sometimes it's brushed off as kind of growing pains. But then kids will start limping and they'll have, decreased physical activity, and they'll not be able to hold on to heavy objects anymore. You might eventually feel a palpable mass. They may have respiratory distress, depending on where their bone tumor is, and fever. Typically, prognosis for bone tumors are pretty good. It's diagnosed through history and physical. You obviously have to rule out any trauma or infection as a cause for the limping or decreased tolerance of physical activity. Okay. Looking for signs of inflammation, the size of the mass, anemia. Weight loss is pretty common. You're going to be managing infections with these kids as well. Okay. Usually treated with chemotherapy. Okay. Radiation is also completed at times, depending on the cancer of the bone. Okay. X-rays, CTs, MRIs, and biopsy potentially. Osteosarcoma. This is probably one of the most common bone tumors you see in kids. It's going to predominantly be found in the lower extremities along the growth plate. Okay. These kids will have surgery and chemotherapy. Surgery is typically for a biopsy to see how much of the limb is affected. Okay. They try and save as much of the limb as possible so that way they can get prosthetics. Okay. But sometimes the entire, a large portion of the limb has to be amputated. Chemotherapy is also done in these cases. So you can see here the osteosarcoma was within the femoral portion on this left side. So they amputated the portion of the femur that was affected and then attached the lower portion of the leg. So that way they can have this prosthetic instead of having to take the entire leg. Okay. Oops. Wilms tumor. So this is the most common kidney tumor of childhood. Now, the thing to remember about Wilms tumor, if a child has Wilms tumor, you do not want to be palpating their abdomen at all. Okay, because it's a really um, uh, flaky tumor, fragile tumor. Okay, so if you palpate, you push on their abdomen, it can kind of encourage that tumor to spread. Okay. Kids with Wilms tumor, especially if it's progressive, their belly will look just like this. They'll have ascites, look like they're really swollen belly. Okay. Usually firm, non-tender on one side. Okay, with deep palpation. But like I said, you don't want to routinely palpate these kids once you know that they have Wilms tumor. Okay. It's diagnosed by history and physical exam and signs of malignancy. So that weight loss, they're obviously enlarged abdomen, all of that. These kids are going to be having ultrasounds, MRIs, CBCs, UAs, and the whole workup.
Would a kid like would something like that they could survive it? The kids like
Well, they still have to have chemotherapy and all of that. So um, it just kind of depends. It's not as survivable as other cancers. Okay.
yeah,
um,
that's sad.
mhm. So if they have more of a complex form of Wilms tumor, their prognosis is obviously worse off. Um, these kids will have both surgery and chemotherapy. They may have some radiation. Okay. You're going to be managing these kids similar to that of other kids who have cancer. Once they identify Wilms tumor, usually they have surgery within 24 to 48 hours. And like I said, do not palpate the tumor is the biggest thing. So a lot of times these kids will have a sign that literally says, do not palpate their abdomen at the bedside. Okay. Make sure you're talking to parents about not pushing on their belly as well. Okay. Usually post-op care, monitoring their bowel function, just like you would with anybody who has an abdominal surgery. Okay. Monitoring for infection as well. Okay, retinoblastoma. This is a tumor within the retina. Okay. Usually caused by genetic alterations in utero. Okay. This is that whitish glow of the pupil when a light is shined in instead of seeing the red eye. So you're actually seeing the tumor there. A lot of times they'll have strabismus, so they'll have, the lazy eye. And then eventually, if it's not caught early, then they will have blindness. Okay, so you can see the tumor here again. Radiation, chemotherapy, sometimes they will surgically implant iodine for the radiation to get like a more accurate right at that tumor within the retina. Okay, cryotherapy is utilized too. So performing a really detailed family history, a lot of times there's others in the family who have had retinoblastoma or eye conditions. Okay, you're going to be working with the parent on a lot of times they have to have an eye implant. Okay, or an artificial eye potentially. Okay, so working on parents and the child adjusting to that. Usually this is diagnosed pretty quick in infancy. Germ cell tumor, so testicular cancer is one of the most common childhood cancers. So boys are at highest risk from ages 15 to 25 for testicular cancer. Teratoma is also a common germ cell tumor. And those are commonly found within the ovarian, within the ovaries. Okay. Usually teratomas can be resected and then no longer require any further workup. Okay. Testicular cancer, they'll typically have to remove that testicle. Teaching all adolescent males to do testicular self exams routinely, just like you teach females to do breast exams. Okay. If they feel anything abnormal, they need to be seen right away. Okay. Liver tumors, surgical resection is usually what's utilized for treatment. And chemotherapy also can be a part of that as well. Transplant is utilized when resection is not possible in a kiddo with a liver tumor. Not something super common in kids, but a possibility. The 5-year survival rate for a kiddo with childhood cancer is about 80%. Obviously, complications that go along with that are typically related to the treatment process. Okay, so infections, rejection of therapies and things. Okay. Okay. We're going to do some Kahoots here now for the last few minutes. Any questions on that? What we all just went over. No? There is a helpful handout in the announcements for this week as well. That might be helpful for you guys to peek at. We have about, let's see, 17 minutes left for you guys to get your full time. Make sure you guys are staying on camera, okay? I understand if you run to the bathroom really quick, but send me a message if you do that. That way I just don't see that your camera's off. Okay. So Monica, if you can turn your camera on for me, please. Okay. Okay, you guys should be seeing my Kahoot here. Oh, hang on. Let's see if it's gonna load. Okay, finally here. Share my screen again here in just a second. Okay. And remember, using Kahoots is a part of your class attendance, so you guys need to be joining. Okay. And in the future, if I ask you guys to turn your cameras back on and you don't respond back after a couple of warnings, and you don't respond back to your chats, then I will remove you from class and we will not be restarting to add anybody again, okay? So just so you all can be aware of that. All right, there are 23 of you guys on, so I should have 23 of you here.
I cannot get in. I don't know why.
Are you on Kahoot.it? Are you doing the app?
This number is that depend number, right?
Yep.
And where do I put it?
It will give you an option. You can either do www.kahoot.it or use the app and scan the QR code, or use your camera and scan the QR code too on your phone. Remember, make sure you guys are staying in camera view. We've had to get really strict about that. Okay. Okay, we'll go ahead and get started here. You should still be able to join. If you haven't been able to join it, we'll give you the code at the top to put in. Okay, a child is admitted with neutropenia. Which nursing action takes priority? Maintain strict hand washing. What's neutropenia?
Low
Your
white
water
blood
count
cell.
level's low.
Low neutrophils.
Low
And they're
neutrophil.
immunocompromised.
Right. Yep, good. So really high risk for infection. Good. Which symptoms would a healthcare professional expect to see in a child with leukemia? Yeah, so you're going to see bruising, fatigue, bone pain. So they might be limping. Okay, intermittent fever that's unexplained, weight loss without trying. Okay. Okay. And leukemia is what type of cancer? What's affected in leukemia? Is it a solid tumor or leukemia is not solid, right? So it's the blood components that are affected. So it's a blood cancer as well as lymphoma. Okay, a child with Wilms tumor. Which action by a nursing student causes faculty member to intervene? Okay, palpating the abdomen. Where's Wilms tumor? What kind of tumor is that?
In the kidney.
Kidney. Yep. We do not palpate the abdomen if the kiddo has Wilms tumor. Okay. It's a really fragile, flaky tumor that will kind of accumulate to other organs if you're palpating. Good. Your child with ALL, which is a type of leukemia, has recent lab results with a platelet count of 10,000. What's your nursing action? Yep, bleeding precautions. Because platelets do what? What's the role of platelets in the body?
Clotting.
Clotting, right. So if your platelet count is very low, you're not going to clot like you should, and you're going to have prolonged bleeding. What about your red blood cells? What's the role of those?
Carry oxygen.
Yeah. Yep. So if you have those are low, then you're going to be anemic. You're going to have, cyanosis. Good. Child with ALL has a fever of 100.5. What should they do? And ALL is acute lymphoblastic leukemia, one of the subtypes of leukemia. Yes. Medical attention right away. So they're getting chemotherapy. Okay. So they're really at risk for sepsis. Good. Child is having a bone marrow aspiration. What should you tell the child? Yes, good. So you be honest with them and tell them it will hurt a little, but you're going to do everything you can to try to make it as little as possible. Good. Most common clinical manifestation of retinoblastoma. Lorena, because of your filter, you keep popping off the camera. I don't know if it's just because you're not close enough or what, but okay. Cat's eye reflex is your most common clinical manifestation. Amblyopia can happen along with strabismus, but your number one sign that a kiddo has retinoblastoma is the cat's eye reflex. So seeing that white tumor instead of the red light reflex. Okay, good. Your child has been diagnosed with retinoblastoma. Which information is important? Yeah, history of any eye complications. So any eye signs and symptoms. Okay, that's important within the diagnosis process. Goal of surgery for a child with osteosarcoma is what? Yeah, salvage of the limb to be able to use the prosthetic. Okay. Salvage as much as possible. Good. Child is complaining about skin markings from radiation therapy. Should be told what? Yes, the markings are the guide for where they're going to be doing their treatment. Okay. So that picture of the kiddo who had the retinoblastoma, you could see the cat's eye reflex, and then they had an arrow drawn above their eye. That's showing, okay, that's the affected eye. That's where we need to be doing our radiation. Okay. So those have to remain in place while they're undergoing radiation therapy. Okay, what assessment question needs to be asked for a child with possible rheumatic fever? Well, this question's in the wrong category. It's from last week, though, so you guys should remember it. Yep, good. So rheumatic fever goes along with strep. Okay. So if they've had a sore throat within the last couple of weeks or months or an unexplained fever, you get concerned about rheumatic fever. Okay. So that was a free one from week 5. If a child was to receive their own bone marrow, this is called a blank transfusion. Or their own stem cells. Yes, autologous means from themselves. Allogenic, think all. Allogenic, all. That'd be everybody else, right? Okay, that's a kind of a way to think about it. Auto, self. Okay, good. An autologous transplant is going to be a lot easier to tolerate than an allogenic. Okay. What cancer may present with painless, firm, and enlarged cervical lymph nodes? Yes, Hodgkin's lymphoma, painless, firm, and large cervical lymph nodes with Hodgkin's. What type of tumor is Hodgkin's lymphoma, though? What's involved?
Like the lymph nodes?
What was that? Sorry.
You said like lymph nodes? Is that
Lymph nodes, yeah, but what is it, a solid tumor or does it affect the blood components?
Like the blood component.
Yes.
It's not
So it
considered
goes,
a
it goes,
solid tumor.
nope,
It's
nope.
the blood
It goes along with leukemia. Yep. Good, because it's in the lymphatic system. Okay, lymphoma, lymphatic system, blood, lymph nodes. Okay. Okay, multiple select. Treatment of osteosarcoma includes what?
Hmm.
Okay, yes, amputation, potentially, right? Salvaging as much lung as possible, or of the limb as possible, and chemotherapy. Okay. All right, do you guys want to keep going? There's only a few questions left here on the Kahoots. Otherwise, you guys have been here for your class time, so you can log off if you'd like. There's 4 questions left. Okay, and multiple select. Who are the best donors for bone marrow transplantation?
I don't know.
Anthony, you're still unmuted. Yeah, so siblings. Okay. So that would be an allogenic still because it's from everybody else, right? And then an autologous. But your siblings are going to have the most, similar genes as long as you have same parents. So they're going to be most likely to be able to be a close match for you genetically. So you'll be able to tolerate a transplantation from them better than, someone who's not related to you with less likelihood of rejection. Okay. Good. What would you consider to be neutropenia or low neutrophil count in children? Less than 500. Remember I talked about the ANC, absolute neutrophil count, less than 500. That's where they're at the highest risk for infection. Okay, so if it's less than 500, they're neutropenic and they need to be on neutropenic precautions. So that means like no live plants, okay, because of risk of infection. Fevers, like if people are visiting them, they need to be masking, all of that. You need to be masking as a nurse usually and in contact precautions as well. So you're not giving them any infections. Okay, primary characteristic of a brain tumor is what? Yeah, symptoms getting worse over time, right? As that tumor grows and pushes more areas of the brain or impacts more areas of the brain, the symptoms are going to get worse. Okay. Vomiting, you will see vomiting, but it's not necessarily correlated with when you eat. Okay. Obviously, you'll see poor balance, usually with walking. And then headaches wise, it's usually pretty consistent headaches. And if they're not consistent, they're severe. Okay, so like you wake in the middle of the night with a headache. That would be a concerning thing for a brain tumor. Okay. Or headache right as soon as you wake up in the morning. That's kind of another potential sign. The optimum treatment for osteosarcoma is what? I think you guys have had this question like in 3 different worded answers, so I'm sure you all know the answer by now. Okay, well, I would argue that the green one also was a correct answer. So removing the tumor as much as possible with saving as much as the bone as possible. So salvaging the limb as much as you can. Good. One last question here. Okay, a child is receiving the induction portion of chemotherapy. What does that mean? Yes, good. That initial intensive chemotherapy with the goal of radiation or remission, excuse me. Okay. So induction is that 4 to 6 weeks, first 4 to 6 weeks in a protocol where they're going to get everything that they can get all at once to try and get rid of the cancer right away. Okay. All right. Do you guys have any other questions for me for this week? Study, 10 to live review. That will really help you guys. You can listen to someone other than me talk to you. That might help you too. Okay. If you have any questions, reach out. For those of you guys that like to test on campus, make sure you are asking 72 hours before. Okay. If you are not 72 hours before, I will not be able to work with you. Okay. So have a good week. Make sure you guys are doing your sim charts. If you're having any issues with those, make sure you're letting me know too. And sometimes I have to have you reach out to IT for those issues, but just know you're going off of your Canvas dates versus the dates within SimChart. Sorry, I should have clarified that better beforehand. Okay. Alrighty, have a good weekend. Or, well, week, excuse me.
You too.
Yeah, bye.
You too.
Bye.